Hi, everyone. Just waiting for everyone to get fully admitted and then we'll get started here. I know it's not quite 12 o'clock yet, but
Alexa, I think you're talking and you're muted.
thank you. I was just going to say just a couple more minutes. We have some more registrants that are not currently participating yet. So just going to hold off for just a couple more moments. Alrighty, I'm gonna go ahead and get started. Hi, welcome, good afternoon. My name is Alexa. I am the Partner Relations Coordinator supporting both the South and the West RPUs. So welcome to our first ever Lunch and Learn. Before we get started, I just wanna go over a few housekeeping items. Today's Lunch and Learn will be recorded for quality assurance purposes and may be uploaded to our website at a later date. At the end of the Lunch and Learn, there'll be a brief question and answer period, so feel free to type in any questions in the question and answer box that's located at the bottom of your screen. We'll be collecting them and answering as many of them as possible. I would now like to introduce Derrik Chrisler. Derrik Chrisler, Vice President for Human Service Development. Mr. Chrisler has worked in his role since May 2015. Prior to joining HSD, he worked in private industry in human services and staff recruitment fields. Derrik is actively involved with district by participating with 2 performing provider systems in the region. He is an active member on several CCM committees and serves on multiple additional work groups that are aimed at achieving health improvement outcomes based on district project objectives. Mr. Chrisler also served on the NYSAR board from 2016 to 2019, where he served on multiple committees as well as held the vice presidency of the board. Through his work as a NYSAR board member, he actively supports population health activities that are aimed at improving social determinants of health for the Finger Lakes and Southern Tier regions of New York State. Everyone, please welcome Derrik.
Thank you, Alexa. So welcome everyone to this Lunch and Learn opportunity. So go ahead and see if this works. Okay, so that's me. All right, so I'm just going to talk briefly, provide an overview. In looking at the participant list, most of you, it seems, have a general understanding of what DISRIP is, based on my recognition of your name, or at least have been involved. So I won't belabor the point, but what I'm going to be presenting on is an innovation grant and a program that we developed at Human Service Development that helped us partner community-based organizations and clinical providers. If most of you know, the 2CI program, or community navigation, that was born out of the district proposal, was aimed at providing community-based services for Medicaid clients through community-based organizations. So what we did is we wanted to look at how we could improve health outcomes for high utilizing individuals, specifically individuals on Medicaid, access to access community services out in the community. But then also we wanted to take it a step further and look at where these high utilizers were congregating. So we partnered with a couple different health systems throughout the region and embedded community health navigators, or what I'll refer to as CHNs, in the emergency departments. And the main goal of that, like I said, was how could we work with clinical providers to address some of the more social determinant of health needs that a lot of you are either familiar with or have heard that term. So housing, transportation, supplemental medical support, such as pharmaceutical, durable medical equipment, etc. So lots and lots of different approaches to addressing those social needs. Let's see here. So a lot of you know that if you've been familiar with DISRIP, you know what the main DISRIP goals are, and those are listed at the bottom of this slide. But really, DISRIP was aimed at preventing emergency department usage, potential emergency preventable emergency department usage. So looking at, are there opportunities for patients to get medical care in an appropriate setting that isn't the emergency department? Do they have a sore throat? Do they have a primary care provider? Can they go see their primary care provider instead of utilizing high cost emergency room usage? Additionally, would they have the potentially preventable hospital readmissions? Again, They present at the ED, they get admitted, and then they get discharged. Is there a plan for follow-up for both the clinical component and the non-clinical component to keep those individuals out of the emergency room or coming back to the hospital? And then, you know, the true integration of clinical and community-based providers, which is what our program was aimed at doing. We also wanted to work at preparing for value-based payment under the district program. That's kind of what we wanted to do with this program specifically. And if you look at the top there, those are some of the objectives of the program that we wanted to kind of look at so that we could measure those and hopefully then prepare a VBP proposal to take to potential payers, whether that was large health systems, managed care organizations, or even ACOs or IPAs. ACOs being accountable care organizations and IPAs being independent provider associations. So I'll talk real briefly about how this got started. Originally, we got HSD got some small funding from FLIPS, the Finger Lakes Performing Provider System, to develop a emergency department community health navigator collaboration. We were at Noyes Hospital over in Dansville, St. James, and Jones Memorial. And we wanted to really embed the community health navigator in the emergency department to catch those individuals that were not, you know, not intensive. You know, they weren't having a heart attack. They weren't having a stroke. Maybe they were there because they had a sore throat, or maybe they were there because they were homeless and they needed a warm place to sleep for the night. Maybe they needed food, and they knew if they went to the emergency department and were admitted to the hospital, they'd be guaranteed a couple of meals. So we really wanted to look at those high functioning, high utilizers that had low acuity in relation to their actual medical diagnosis. That program was quite a success. We had a really great clinical partnership. Clinical staff adopted the program, and you'll see in some of the statistics I'm about to share, they were very welcoming of our program, and that program is actually continuing currently in a limited function. Additionally, we then partnered with Guthrie Health System and Arnot, both Arnot Ira Davenport, which is out of Bath, and Arnot Ogden out of Elmira. And we worked with them to do the same thing, but with a slightly different approach in that we identified champions at both hospitals to get our community health navigators set up and supported and integrated within the clinical team. So our navigators actually went in and were trained by clinical staff on what the clinical procedures and protocols were when somebody was admitted to the emergency department, and we're actually co-located at the nursing station. So they worked very closely with the nurses and the providers on you know, the same types of services: community navigation, follow-up with primary care physicians, transportation, housing, etc. So what does all that mean? Well, I'm going to share with you some of the statistics that we tracked over a year period. This year period was for our innovation grant fund. So that would have been, it would have been April 1 of 2019 to March 30th of 2020. I believe that's the correct dates. So I'm just going to go through each of these, and then I'll kind of pause. Alexa's monitoring the chat. I'll pause at each hospital and see if there are any hospital specific questions, and then I can try to field those. If not, then we can save them to the end, and I can answer those questions at the end. So the first hospital was actually Arnot Ira. If you're not familiar with Ira Davenport, it's in Bath, and it's a very small hospital. Their census is relatively low. So the numbers here are quite low for the number of people navigated over a period of time. And we did in fact only have a part-time staff person at Arnot Ira. And the reason being, prior to submitting our proposal, we actually looked at peak utilization of the emergency department by payer. So we looked at Medicaid specifically, and the numbers were relatively low, again, related to the census. And that's why we chose to only put a part-time person there. So over the grant period, we had 60 unique patients that participated in the program with a total of 83 interventions. So some patients obviously took advantage of multiple interventions with the community navigator. Of those, 89% were face-to-face. And when you say community setting, we collected all patients were seen in the hospital. So community means that community specifically, not that they were seen outside in the community, they were seen in the hospital. And then 11% were considered telephonic. So it could have been follow-up for those additional patients that took multiple interventions. And so we codify our navigations into different domains. This is a pretty busy slide, and I also offered to make available the raw data. It's de-identified, but the raw data, because some of the colors, they look familiar or similar, so it's kind of hard to tell based on the legend, but the raw data does provide the breakdown, and you can see a little closer to the exact numbers. So again, to our domains, we kind of have these different codes for based on the primary navigation that the client received. So behavioral health, I'll just run through these real quick. Behavioral health is for anything related to substance use or behavioral health cognitive therapy. Caregiving is for either adult caregiving or child caregiving. Clinical PCP is a clinical PCP follow-up appointment, dental follow-up appointment. Disease management is for any disease process support programs. External community-based program is a evidence-based intervention outside of our agency. Financials for financial support. Food and nutrition is for either nutrition counseling or additional food such as SNAP. Health education is general information related to health diagnosis. Housing is housing support. Insurance support for enrollment in insurance, medications, prescription assistance, pharmacological, social support, social support groups. Transportation, obviously, is transportation. And wellness and prevention is specific education that the community health navigator provided to that patient for anything that they needed, but it wasn't necessarily a fully incorporated warm handoff. So obviously you can see the biggest one at Ira Davenport was clinical PCP follow-ups. And then there are other breakdowns as well. So then we looked at the three main, so other is anything from this domain that does not fall into clinical PCP or financial or not applicable. And not applicable would mean they met with the navigator, but they really didn't have any identified needs that they needed at this time, or they met with the navigator and then ultimately refused a referral. So you can see, a pretty good split between clinical primary care follow-ups and other. So all of those other domains included in the previous slide. So that's it for Ira. If there are no questions at this time, I'll proceed to Arnot Ogden. Okay, so Arnot Ogden is based out of Elmira. So obviously a much larger population, much larger census at that emergency department. Over the course of the year, we had 300 unique patients. Of those unique patients, a total of 639 interventions. So a lot of repeat customers, or a lot of patients that received multiple interventions. Again, majority of them being face-to-face in the emergency department, with telephonic consisting of about 19% of the follow-up. So here's the domain breakdown. Probably a big part of this being dental. We saw a lot of dental needs in the emergency department and ended up having a lot of referrals to those. Additionally, we had a good amount for wellness and prevention and a good amount for caregiving. A lot of the individuals that were seen ended up needing support assistance for their children while they were at work, you know, in the hospital or receiving additional support services or treatment. Again, breaking it down into those 3 categories, a large percentage being not apical, a large percentage being other, probably a lot of those other were those dental visits, clinical PCP being about 18 and only about 1% of the overall being financial. Again, these are primary. So this could be coded as, you know, the system that we use to track all of this allows you to select multiple domains, but it only pulls based on the report the primary domain. And so somebody might have the need to follow up for clinical because they had an MI, myocardial infarction, or a heart attack, and they need to go see their cardiologist, but maybe they don't have insurance and they can't afford it. So we helped them with all 3 of those things, but the primary thing being what's the most immediate need, and the immediate need is to follow up with that cardiologist. And I didn't have this for the IRA breakdown because all of them were Medicaid, and it didn't really seem like I needed to put that on a slide. But we did look at the primary payer class for each of these. You know, we were allowed to, under our innovation program, we wrote that Medicaid would be our primary beneficiary for this program. However, if people were presenting and there weren't Medicaid patients at the time, we would assist those that qualified under other payers. And so this is the Arnot Ogden breakdown for the year of those patients. Obviously, 72% of them were Medicaid managed care, with the next largest being Medicaid fee-for-service, and then the additional breakdowns. You know, uninsured, most likely those were eligible for Medicaid and either had a referral and we tried to follow up with them and lost touch with them, or they weren't interested in accepting additional insurance. Also, this doesn't take into account those people that are Medicaid and Medicare dual eligible. So it's primary payer class only. So if they are Medicare first and foremost and have Medicaid secondary, that wouldn't show up in this graph. As mentioned before, we also worked with Guthrie and specifically the Corning Hospital. As you all know, DSRIP is a New York State program. So we worked with Guthrie Corning Hospital. 704 unique patients, a total of 894 interventions. Again, significant amount of repeats. Obviously, most being face-to-face, but a fair amount of telephonic follow-up. And the interesting things that we learned, sort of lessons learned that I'll talk about throughout this data is that, you know, we took different approaches with each hospital based on the clinical feedback from each of the providers in the hospital, in the emergency department. And the providers at Guthrie really wanted us to focus our work on outreach to those high utilizers that were coming into the ED when we weren't there. So we weren't there 24/7. We were there during peak utilization, but sometimes they would come in and there wasn't a community health navigator to meet with them. So then we would get the referral from the clinical providers the next day and then follow up with them. So a fair amount of telephonic outreach. For this one, we had a lot of wellness and prevention. That's that 32% there, and a lot of transportation, the 29%. So a lot of transportation needs seen, as well as just generalized support and education from the community health navigator. And probably the next closest would be 9%, which is insurance support. So getting people hooked up with either refiling their Medicaid application, or they're uninsured and they need assistance with filling out their application, or really anything related to insurance. They need an advocate for Medicaid hearing. They need help with applying for charity care. Any of those types of things would fall under that category. The majority was other for Guthrie. Not a lot of clinical PCP, not a lot of financial support, and really not very many not applicable. A lot of other, as you can see from this previous slide, a lot of smatterings of different data, lots of random issues that people needed help with. I included this because of the outreach, the number of outreach that we did with Guthrie via telephone. A lot of people that we called, we actually had a list created from the Guthrie Epic EMR of high utilizers, and specifically targeted those people that hadn't been into the hospital but were high utilizers within the previous year, the claims data. And a lot of people, when we outreached them, they flat out refused, about half. A good amount of them, we ended up navigating, about 27%, and 13% we ended up leaving voicemails with and never received a response. So interesting there. Again, different approach with Guthrie related to the telephonic outreach. Definitely a lessons learned. Primary payer class, again, majority being Medicaid. We have a good Medicaid fee for service, and then a smattering of the other insurance plans. I'm not sure, do we have, oh, okay. So I'm going to pause here because I got a couple of questions. Derek, on both graphs, housing is listed as a category, but not listed with the percentage. Is housing insecurity was that low or identified, or did you not have the means to address lack of housing there where the percentage weren't listed as interventions for the first two locations? So let me go back, sorry, first two locations. So we're looking at IRA and Arnot. So we have housing, let's see, housing. So Brown, so yeah, it's probably one of those 0% for this one. And the 0% mean it was like 0.1% or less than a percent. So that means of those interventions, it was probably one, or it wasn't the primary need for IRA. And then for Arnot Ogden, for housing, we have the brown color, that's 1%. So 1% of 639 total interventions. It's a very, very low number. That's why they're more difficult to see. And again, I can provide those breakdowns with the raw data. I'll make that available, and if CCN posts that or sends it out as a follow-up to the participants, you can look a little closer into that. I don't have that open right now. Okay, so Noyes Health, again, the majority being here, a lot of telephonic breakdown, a lot of follow-up for those individuals or outreach from the emergency department. Over the course of the year, 499 interventions, 344 unique patients. Breakdown here, a lot of insurance support. So Noyes saw a lot of uninsured patients coming in, and those uninsured were given to the community health navigators as referral, and then they would call as follow-up and try and help enroll them into insurance. The second highest being, I believe that's dental or not applicable. Again, those numbers are so close. I'll have to look at that a little bit closer. I mean, the colors are so close. But primarily, the big portion here was the insurance support, about 0.5%. So if you take a look at financial, again, big portion of it being financial. The financial does fall under insurance support because it is considered a financial assistance because they needed help with either filing those applications or had charity care needs or anything along those lines. The other would be 16%. That would include any of the ones that did not fall in. About 6% clinical PCP, and then not applicable. Again, they either refused or didn't take an official navigation as we define it. Again, this goes in lines with what we saw about insurance support. About 54% of the people helped at Noyes Health had an insurance need or an insurance navigation, and they were uninsured. Next being Medicaid managed care, and then a small amount of the remaining. We're on to St. James now. Most of those being face-to-face, about 70-30 split. 877 unique patients and a total of 1,639 patients. So a lot of these patients had 2 or more navigations. As you can see, it's almost 1 patient per 2 navigations. So quite a lot. Almost all of them were clinical PCP or clinical PCP follow-ups. You can see a lot of those are 0%, so it was less than 1%. Very, very low number, that was in the point, 0.1s, 0.2% of those navigations, of those 1639 navigations. So a lot of follow-up for clinical and I believe that's dental. So obviously this graph is going to match those other ones. About 86% breakdown for clinical, 5% for other, 9% for not applicable or refused, or not needing anything, and then less than a 0.1% for financial. Majority being Medicaid, Medicaid fee for service, Medicaid managed care, about 15% and uninsured, and a smattering of the other ones at St. James. Okay, so I moved through that data rather quickly. I wanted to leave enough time for questions. I did get another question, but as you have questions, or if you want me to answer anything specific, or if you want me to go back to a specific graph, I can do that. I can go back and forth pretty easily. So I'll just take this question, and then we'll leave a few minutes for additional questions or comments related to any of the graph that we went over, or any questions about our program and how we implemented it, or some of the differences between those. So most of the uninsured students in Rochester. We don't collect, oh, hang on, sorry, I went further. So for this one, for the University of Rochester, for Noyes and St. James, we don't collect if they're a student in our system. It's just not a data point that we look at. I'm trying to find the uninsured, I'm sorry, here. So this is Medicaid, no, so it would have been Noyes that had the high uninsured. I can say from talking anecdotally, from talking to the navigators that were there, they had a larger Spanish speaking population, and a lot of them were migrant workers that would come in from either the northern area, like Wayne or Ontario County sometimes, seeking care. And so they weren't always aware that they didn't have insurance, or they didn't believe they were eligible. So there was a lot of education around eligibility and support for people that were uninsured. So I can't really answer that because we don't collect that data. I'm sure we did see a fair amount of students, but one of the things that we do know from the Affordable Care Act is that if you're a student at a university in New York, you actually are required to either take the school's insurance or waive it with proof that you have insurance. So you can't actually refuse it. So I'm not 100% sure on if it would have been a lot of students based on that requirement. Another question, what portion of this program do you wish or feel to be the most necessary to sustain going forward? That's a really good question. I think probably the biggest, no, I just lost it. Okay, I feel most sustained going forward. Probably the biggest thing, sorry, I keep clicking and advancing the slides. The biggest thing is support for the community navigation resources. And what I mean by that is the staff time. So through our first grant with FLIPS, and then our second grant with Care Compass, through the innovation grant, we were able to support staff as sort of like a pilot regardless of performance. Obviously, you can see from this data and the number of interventions that we provided, our value was significant, because we also, one thing that we can talk about anecdotally, and we're looking at some of the data we did collect, and are we able to state, did we help clinical providers work at the height of their license? If we did that by addressing some of these more social needs, we ultimately generated revenue, right? Instead of a registered nurse or a provider having to sit on the phone and deal with the transportation issue for a patient because it's a real big issue, that could be taken on by the community health navigator who has that time, who has that skill set, who's been trained to support those needs in a meaningful way, and allow that provider to work on more of the clinically appropriate needs. So to answer your question, we need clinical buy-in, we need support from the managed care organizations, and we need funding to support staff. Looks like a couple more questions. Let's see. At Guthrie Corning, did those who refused services indicate why? We have a case notes section, and we do collect some information. It's pretty limited, and we tried to implement a formatted version. It didn't work out 100% because it was new. Our staff are not trained clinically, so they weren't really used to the type of formatting for case notes. So we may have some of that information, but it's not as cut and dry. It's more qualitative than quantitative. Were the objectives of reducing ED usage and readmissions met? That's something we're looking at. We're looking into. We wanted Care Compass Network to provide claims data for the time period that we provided it. The problem with claims data is there's a lag in claims data. So we actually went to each of the individual hospitals and asked for additional data to look at whether or not those individuals did indeed not utilize the ED in the future after receiving community navigation. Unfortunately, with COVID hitting right around the time our grant was wrapping up, a lot of the hospitals struggled with providing that data because they were dealing with a lot of other issues. We're still looking into that, and we hope to have some future discussions around looking at that data and really identifying whether or not we have met those objectives. Is there any negotiation between HSD and these clinical partners about how the community navigator would fit in with existing work? I think where the community navigator was placed on the workflow had anything to do with large differences in services provided at different sites? That's a really great question, Emma. Absolutely. Prior to, so especially for, well, really with all the hospitals, but it was a little different because with the FLIPS program, it was a very small pilot, and then it kind of developed beyond that, where it was piloted, I believe, for 6 months, and it was such a success, and the hospitals loved it so much that we got additional funding support from FLIPS to expand it and hire additional staffing. So for that, both the hospitals had buy-in initially, and then we integrated in the workflows, and it was so successful, and there was so much work that we brought on additional staff at each of the hospitals. For Guthrie and Arnot, had a hand in crafting the proposal that we wrote to CCN. So they were already in the negotiation, as you call it, for workflow. And we had a standing monthly meeting with both Arnot ED providers and Guthrie ED providers. One of the biggest challenges with that is turnover in the emergency department. There's a lot of turnover in the emergency department, more so than in some of the other clinical settings. So that was one of the challenges that we saw in relation to the differences in services provided and integration of workflow. So, we would train the ED staff, and they would be all for the program and super supportive. And then our main champion would leave after a couple of months. And then that would require us to train them all over again. So that was one of the big problems. So excuse me for 1 second. I just need to check.
All right, Derrik will be back in just a moment. Do think we have a couple more questions, so just bear with us. Sorry about that, guys.
Okay, I'm back. My apologies. So next question, were the ER high use times consistent or did they vary by hospital also? Really great question. So the information related to the ED usage, we did look at peak usage, and one of the interesting things was that different hospitals did have different utilization, but a lot of it was I believe, and you're putting me on the spot, and I have it, it's written in our proposal. I believe it was 3 p.m. to 11 p.m. and it was Sunday through Thursday. Don't hold me on that, but Dorothy, I can also include that breakdown in the follow-up with the data, but I'm pretty sure that was the highest utilization for Medicaid times. One of the interesting things that we found out about that though was with Guthrie specifically, we initially started off with those hours of 3 to 11:30, but we quickly needed to change that because of the support of the ED staff. We needed to support their needs so that we could continue to get those referrals from them. And we ended up changing to 11 to 11 and doing 4-hour days so that we could have more time for follow-up with community-based organizations. So if a client came in after hours, a lot of CBOs are only open from 9 to 5 during the weekday. So if they came in after hours, like 7, 8 p.m., we would have to follow up the following day. Well, if the community health navigator doesn't start until 3 p.m., and they have to do all of this follow-up with the clinical providers as soon as they get in, that doesn't leave a lot of time to do that follow-up for the patient and connect them. So we quickly changed those hours from 11 p.m. to, or 11 a.m. to 11 p.m. But yeah, it seemed like there was some consistency across the board of peak utilization between Sunday at 3 p.m. and 11 p.m. through Thursday at those times. And I think that's all the questions. I tried to get to them. Are there any additional questions at this time? Or if you think of them after the fact, you can share them with Alexa and she has all my contact info and I'll be happy to answer them. We are looking at possibly continuing this program. We are still at St. James Hospital and we've seen a ton of success at that hospital, and we're looking at ways to take all of the data that we have, it's a lot of data, and develop our VBP process proposal and hopefully get additional funding for that in the future. So
Perfect. Thank you so much, Derek.
Yep. Thank you, everyone.
After this, there will be a brief Zoom survey. If you could just take a few moments to provide us with your feedback, we'd really appreciate it. And again, on behalf of Care Compass Network and Derrik Chrisler, we thank you for joining us today for our first ever Lunch and Learn. Have a great rest of the day and enjoy your weekend.